have a very special person from the Veterans Administration Healthcare System in Oklahoma City. So we want to welcome Stephanie McKay. Thank you so much for leading this conversation on this very important topic. And I am going to turn it over and let you jump to it.
Well, thank you. Thank you for having me. And thank you to all the folks who are listening today or who are going to listen to the webcast after today. I just want to take a second to say thank you for all of the work that you're doing across the state of Oklahoma and beyond. It's valuable work, and I'm excited to be a part of this network and help provide some resources to our veterans in Oklahoma. So with that, I'll go ahead and get started. I just want to let you know, please, if you have any questions throughout the presentation, I'm pretty easygoing. I like to answer questions as they come. So if you do have any questions while we're chatting today, go ahead and enter those in the question box, and I will answer them as I'm able and refer you to places that I maybe have to if I'm not able to answer those questions today. So I will begin. A little bit about the history and development of the VA's Intimate Partner Violence Assistance Program. I had a lovely video here, but I wasn't able to send it, so I'll give you kind of a verbal overview of the program. Back in 2012, the VA developed a task force, and they wanted to understand and develop a national policy and program to promote the safety of veterans who use and experience intimate partner violence. They wanted to provide services and support and to support the veterans for their health and well-being. From there, 14 key recommendations were developed. Those were developed to serve our veterans, families, caregivers, and actually our VA employees as well. In 2014, the first national program manager was hired, and the program was implemented at 6 test sites across the United States, with a veteran-centered, trauma-informed, and recovery-oriented outlook, which we'll cover what those mean. At the same time, there were a lot of folks that were coming together across the country to support the work, and over the next few years, many new coordinators joined, and the program continued to grow. In 2017, the program got a new program manager, and the 6 test sites finalized their testing on the initial implementation of the program. More work groups were formed, and with those were raising awareness, program evaluation, training and education, and documentation. Those are the 4 work groups that continue within the VA today under the Intimate Partner Violence Assistance Program. In 2018, right around March, the IPV program was officially fully funded for the 2018 and 2019 fiscal year, allowing each catchment area to have a full-time IPV coordinator. So catchment area, Oklahoma City is the main hospital VA, and we have many CBOCs or community behavioral health centers that we reach out to within our community. So for myself, I am the full-time IPV coordinator, and I reach down to Wichita Falls. I cover the Lawton area, Ada, Ardmore, and up to the Stillwater area, and we just recently hired another IPV coordinator for our Muskogee office. So we've got 2 in the state of Oklahoma. You can imagine that as that program grew, there was more interest, and I expect that we continue to develop more and more across the next few years. So again, just to reiterate, in 2019, the VA Intimate Partner Violence Program has over 160 sites. So kind of considering that we went from 6 in 2012 to just over 160 here in 2019 with full-time coordinators at all those sites, and that's expected to increase. Right now, we have 90% of our VA healthcare systems have that dedicated full-time staff. And the job of that coordinator, like myself, is to educate, advocate, and promote the vision and mission of the Intimate Partner Violence Assistance Program. Bear with me 1 second. I see one question here. Okay. Oh, yes,
Oh.
the slide was blank because it was supposed to be a video in there, but I just described it. There's going to be 2 other upcoming slides that are blank as well. Thanks for asking. So a lot of folks ask, what is intimate partner violence? I know many of you on the call right now may have heard that terminology. However, a lot of our veterans aren't real sure of what exactly that means. So intimate partner violence describes physical, sexual, or psychological harm or stalking behavior by a current or former partner that occurs on a continuum of frequency and severity, ranging from emotional abuse to chronic severe battering or even death. IPV can occur in heterosexual or same-sex relationships and doesn't require sexual intimacy or cohabitation. The VA back in 2012 did take the definition that was proposed by the CDC, and again, it was updated in 2016 by the CDC. That's the definition that we operate from today, and we do that for a very specific reason, which I'll talk about further. The vision of our program is that veterans, their families, and caregivers who receive care from the VHA and VHA employees will not experience or use violence or abuse and will be free from the negative consequences resulting from such violence. Our mission, which is a national mission, is to implement a comprehensive, person-centered, recovery-oriented assistance program for veterans, their families, and caregivers, and VHA employees who use or experience intimate partner violence. A lot of people ask the question, how is domestic violence different than intimate partner violence? Well, many of you may know domestic violence by definition is a pattern of abusive behavior in a relationship that is used by one partner to gain or maintain power and control over another intimate partner. It can be physical, sexual, emotional, economic, or psychological actions or threats of actions to influence another person. I won't cover the definition for IPV again. It is there on the screen, but we do know that intimate partner violence is a very specific type of domestic violence. We intentionally use that definition, again, reiterating to the slide before, because it does have a wide range in scope, and our goal is to raise awareness about all types of intimate violence. We have a focus on early intervention and prevention, and we recognize that hurt people hurt people. And so the goal of the IPV program is not to shame or blame, but rather look at veterans who are using violence and veterans who are experiencing violence in that continuum, which I'll talk about further in a minute. The Oklahoma City VA has some core values that we put into action within the IPV program. We go by the phrase, I care. And the I care stands for integrity, acting with that high moral principle and professional standards, maintaining trust and confidence within and outside the VA. Commitment, we work diligently to serve our veterans, other beneficiaries, and our staff. We fulfill our individual and organizational responsibilities. We advocate for our veterans to be truly veteran-centric by identifying and fully considering appropriately advancing the interests of our veterans, beneficiaries, and staff. We treat all those that we work with respect and dignity, and we show respect to earn respect. And we strive for excellence, or the highest quality of continuous improvement. We're very thoughtful in our decision-making, we accept accountability for our actions, and we work towards continuous improvement. So we ask the question, why is this program vital to our veterans, their families, caregivers, and our employees? And I'll cover that more in a second. This was the slide I was referring to that was also blank. We had a really great video. We did, about 2 years ago, a video competition from all over the country of the folks who were working as coordinators in the IPV program. And there were many wonderful submissions showing the importance of the work. Several of those highlighted some of our veterans who were experiencing violence, but it also highlighted our veterans who were using violence. While I can't specifically, I'd love to share that with you, but I can't today. I can share what I've seen within the Oklahoma City VA. Prior to coming to the IPV program, I was working in primary care mental health. So within that role, many of our veterans would come for their annual appointments to Women's Clinic, or they would come to their annual appointments to our various doctors in our primary care setting. And they would express to their doctor that they had some personal or relationship concerns. Typically speaking, if those were getting in the way of their overall health, they would be referred to primary care mental health, which is where I was prior to taking this position. I can't tell you how many folks came through the program and shared with their doctor very personal and rich details, sharing some of their experiences with domestic violence or just stress within their relationship. I'm going to share a story with you today. One of my veterans that I work with and continue to work with today came in through our primary care program. She was very stressed, recently went through a divorce, very confused about that process, and was entering a stage in her life. She's about 50s, 60s, and she was kind of thinking, what am I doing? Who am I now? I met with her briefly through our primary care program, and she quickly realized as I transitioned to the program and talked more about domestic violence, had those kind of posters up in my office and kind of food for thought, that she actually experienced domestic violence in her relationship. She's since attending our group, which we call Sustaining Change, which is a weekly support group for veterans who have experienced violence. She said that she was married for 25 years. And until she watched a Dateline episode and until she saw the posters on my wall, she didn't put two and two together that she was in a relationship that had domestic violence. She shared that often, about once or twice a year, her husband would get upset with her prior to cell phone days and would leave her at a mall an hour to 2 hours away from home. Again, she just knew that they got divorced. She didn't put these things together. I've been able to see this woman weekly since this within our group, and I can't tell you the change that I've seen in her. It truly goes back to our values. We treat each person who comes to us with integrity. We're committed to saying what are the underlying issues. We advocate for them. I was able to get her to see a psychiatrist and to kind of process some of those feelings she had about that. We treat her with respect, and of course we strive for excellence. If there's something that we don't have within the VA, I always turn to all of my resources, like you all in the community, and reach out and say, how can we all work together? We don't want a siloed program. We know that one resource is great, but many resources are better. And so that is my goal, to educate and advocate for our veterans. So again, another blank slide because it would have been another excellent video, but I'll highlight on one other piece here. One of the things that I really love about this program and I'm really excited about is that we also, besides our veterans, we consider our staff. I can't tell you how many staff members I've talked to that said, you know what, I've experienced domestic violence. I didn't think that I did until you said it that way. As many of you may know, January was National Stalking Awareness Month. I sent out kind of a PSA to our staff members, and within minutes, I got several folks back that said, I'm being stalked. Can you help me? I was able to reach out to those folks and refer back to folks like you in the community to say, what can we do? How can we help? What a great resource that we have that, because we know we can't provide good services, we can't fulfill our I-CARE values unless we're well ourselves. So again, I just can't reiterate enough how glad I am that this program exists. So some folks ask, how are we different? Well, we have 4 pillars of how the VA program might be a little bit different than some other programs that do exist in the community. Of course, it's veteran-centric, and many of you maybe had to know what the secret word was today, and that secret word is veteran-centric. So I'm going to go in detail about what that means in a moment. Our program is also person-first. I'm going to talk about that more in a moment because that is really something that's been a little bit controversial within the community, and I'll talk to that in a moment. It is trauma-informed and recovery-oriented. So veteran-centric, what exactly does that mean? We know veterans have unique needs. Many of you in the community may be veterans yourself, and I would assume that all of you have at least worked with one or two veterans. Veterans tend to have mission-focused training. So what that means is, think of basic training. A lot of my veterans come to me and they say, we didn't have time to deal with emotions. We were told to complete the mission, put your feelings aside. I hear that a lot in the work that I do. And so what that tends to do is that sets up, I can't say for everyone, I don't speak for everyone, but for some of my veterans, quite a few of my veterans that I've worked with have said that it's often difficult to reorient back to family life and reorient back to healthy relationships, because when they are mission focused in all that they do, it kind of sets some of those important emotions aside when you're in a healthy relationship. Also, what mission-focused training tends to do or could do is create an environment where a veteran may have some decreased frustration tolerance. I often hear a military versus civilian value set. And so what that might mean is, unfortunately, I'm a civilian myself. I have not served in the military, and my veterans like to point that out, because if I'm a couple minutes late, that's incredibly disrespectful. And so I understand the importance of that. However, that might not be something that if you were going to be in a relationship with a veteran that you'd be as aware of. And so I do hear that a lot within this program and also just generally within the hospital, that kind of military us versus them culture and kind of breaking some of those barriers down. So veteran-centric means that we're aware of those concerns or those potential concerns, and that we can talk about those in a way that's meaningful and brings attention to them. That mission-focused training might also mean that there's a potential for increased anger. If I have a lot of emotions and I'm a veteran's partner and I'm not being mission focused and my partner feels like I need to complete my mission, that could cause some tension within our relationship. We also know that there's post-traumatic stress, the reality of that. There's clinical and psychosocial issues related to military service, particularly when that service has been in combat or dangerous or traumatic assignments. I can't give you a specific percentage because I haven't seen that data. All I know is that a lot of the folks that I work with who are experiencing intimate partner violence have PTSD or have military sexual trauma, often called MST. And so what that means is not necessarily that PTSD equals IPV or domestic violence, but there's a lot of clinical and psychosocial issues that relate to that. Sometimes what we see with PTSD is a lot of numbing or avoidance behavior, and we know that that's not very helpful in our relationships that are experiencing domestic violence. We also know that there's military and family life stress. Can you imagine, and maybe you've been in this boat, picking up and moving every 2 to 3 years, your partner being present for 3 months out of a 12-month year and then leaving again, then coming back and having to orient to that. We know that a change of duty station, family support might not be geographically possible. I can't tell you how many folks, they start out in one area, you get a good friend group going, and then as soon as you're comfortable, you move again. Or what if you're from Oklahoma, or your duty station is Oklahoma, and your parents are in upstate New York? There's a lot of problems with logistics of that. How do we find a babysitter? But there's also a lot of problems with, what if we need to talk to somebody? Sometimes it's not so easy if mom or dad are not next door or your best friend. So that causes a lot of tension too. And again, just the separation and isolation. We talk about that on both sides, the partner side and the veteran side. The military does a really great job of creating what we call battle buddies. And what those are those people that you know you can trust, day in, day out, kind of, I use the phrase ride or die, right? They really, truly are. You have to trust your life to someone else when you are in combat. And when you come back, you might have the greatest relationship with your partner. But if your life was in danger, who are you going to trust more? The person who saved your life or your partner? It's kind of a hard thing that we often don't talk about. So there's a lot of separation and a lot of isolation. either that or, again, for the partner. If I'm in my town where my duty station is, my partner's been deployed for 15 to 18 months, how do I address that? How do I deal with that isolation? That can cause a lot of tension within relationships. We also know that veterans have some unique mental health concerns, and I'll talk to this. There are perceived and actual barriers to service sometimes. Perceived barriers to service. Many of my friends, my partner, some of my past partners have been veterans, and I know the discussion of mental health and the utilization of mental health within a military population is often seen as something that's not only negative, but incredibly scary and can end a career for some folks. The military is changing that culture, but we are aware that there's a lot of stigma to a mental health diagnosis, and there's even more stigma to the legal aspects of domestic violence. And so a lot of the time, there's perceived barriers, but maybe there's actual barriers. What if you're deployed? Most sites do have social workers or psychologists. However, if you've been deployed for 15 months and now you're back stateside, there might be some actual barriers to services. Being aware of our different coverage areas. Oftentimes, we have so many folks who are coming back and are high users of our services. It can be a 2-week to 4-week wait for some people. And so that is a real barrier to services. So we know that we're working to reduce that within the VA, always developing those programs, but that can be something that's part of our veteran-centric factors as well. And again, referring to not all veterans are using substances, but that does occur within the veteran population, a loss of overall trust of systems and of certain people, moral distress. I can't talk about that enough. That is a central factor to a lot of our veterans who have come back and have done things that are against their moral code, but are part of their moral code because they took an oath and an honor to protect and serve. And so there's a lot of moral distress with what had to be done versus what was done, and how do you come to terms with that? And then, of course, our last one is the very real fact of traumatic brain injuries due to being in combat. Again, those would all be considered veteran-centric factors that would play into understanding intimate partner violent relationships. We know, having gone over those veteran-centric factors, that is more likely to be an increased risk of divorce and broken families. I don't want to say joke because it's not a laughing matter, but kind of a side thing that a lot of military folks talk about is this your second, third, or fourth marriage? I hear that quite a lot, and I would love to take statistics on that sometimes, but we know that a lot of our military folks do have a lot of divorces, and those are because of those factors that we talked about. And so if we have one divorce, we're more likely to have two. If we have two, we're more likely to have a third. A loss of support, homelessness, joblessness, poverty, increased healthcare needs, justice involvement, and suicidal or homicidal ideations, plans, or intent. We do know that there's a very strong connection between intimate partner violence and suicide or homicide, and we're very aware of that in the veteran-centric factors. A lot of those isolation and lack of control plays into that. Within the general population, we look at intimate partner violence, and we know that about 1 in 3 women and 1 in 4 men experiences intimate partner violence across their life. We know within the veteran population that's actually twice as likely. So 2 in 3 women and 2 in 4 men. And that's according to the National Coalition Against Domestic Violence in 2016. That was our first tier. Our second tier is the person first. So again, I knew this area is a little bit tricky for some folks, and this is kind of how do I say, a point of frustration amongst community, I've heard, and I want to acknowledge that. Part of what the VA has said is veterans using violence and veterans experiencing violence. And we are, from a national down standpoint, encourage strongly to discourage the use of the terms batterer and victim. And I'll talk more about that in a second. Part of the IPV program is to use that person-first language. The IPV program is mindful of the contextual, situational, and bidirectional forms of intimate partner violence in which relationship stressors overcome the couple's positive coping skills. So why we do that is that we want to be kind of decreasing the stigma of talking about domestic violence. We want to recognize those early warning signs. Is there frequent arguing within the relationship? Is there name calling? Is there threatening? Therefore, language is very important to us and to our program and to our work because it is person first. Again, using terms, veterans who use violence. That would be a veteran who is using violence within an intimate partner relationship. And veterans who experience violence. And that would be a veteran who's experienced violence within an intimate partner relationship. We want to reduce that stigma, and so I can't say enough. We avoid using terms such as batterers or victims. However, we do know that those are important within our community, and those have greater meaning. And so when I'm talking with people individually, I kind of let them decide that, but when we're doing more education, we want to be aware of that person-first language. Our ultimate goal is prevention and intervention. And if we can use the term a veteran who's using violence, if that's going to get somebody more likely to into our door and into our services, that's what we would like to have happen. So that was our second tier of how we're different. Our third is that we're trauma-informed. So again, person-centered, avoiding those stigmatizing labels, recovery-oriented. We empower the individual. I'll speak on that a moment. I had a phone call this morning with an individual who's seeking services. They said, you know, I'm ready now. And I said, I'm really glad. I really wanted to follow up with you, but I wanted you to make that decision. We don't send for our appointments out of our program, we don't send reminder letters. We don't do reminder calls because we know that that might not be safe in that home. So we want to really empower the individual. We know that intimate partner violence is a lot of power and control and coercion, so I want people to come willingly to my program and to my office. We're culturally inclusive and sensitive. We use person and environment approach, and we do consider the impact of trauma when we look at that therapeutic environment, when we're writing policy and when we're determining our procedures. Trauma-informed care is, again, an organizational structure and treatment framework that involves understanding, recognizing, and responding to all the effects of all trauma. We know that trauma happens in the military, but we know that a lot of folks have trauma prior to the military. So trauma-informed care emphasizes physical, psychological, and emotional safety for both consumers and providers, and it helps us build a sense of control and empowerment in the folks that we serve. And our last tier is it's recovery-oriented. Some of the same words there, person-centered. It's inclusive of the veteran's family and all the other allies that are identified as supportive. So if you want to have your brother be part of the program and that's somebody that's part of your intimate network, then that's something that we can work with. It's individualized, comprehensive services, and it considers the lifespan. It's anchored in the community, including the VA, but more the greater community in which the veteran engages in. We know that I can provide a lot of services within those doors, but if the family's not well, if there's dynamics that are happening within the family, and we know there always are, then I have to refer to maybe some family therapy too. So again, going back to it, we don't want to silo a service and provide something that's not going to be useful in making institutional or a greater change within that system that person's coming from. It's continuity of care, partnership, and consultant relationship. So I always ask my veterans, and it's kind of confusing for some folks, I'm not going to put canned treatment goal statements. If people don't want to work on a certain thing, if they have some charges but they don't want to talk about that, well, that's where we're at. So it's really meeting our veterans where they're at. It's really strengths-based. It's culturally responsive to personal belief systems. Just because I don't see something one way doesn't mean that it's going to work for somebody else or not going to work for somebody else. So we're aware of that and oriented to that. Inclusion of the voices and experience of the individual, their family, and their caregivers, and it's integrated, again, avoiding that silo servicing. System-wide, and we do a lot of ongoing monitoring and outreach, as well as outcome-driven. The goal of increased connectedness and positive relationships with other human beings, and it's very research-based. So again, one of the questions that you all had on your sheet today was, what's the difference in comparison of IPV prevalence across the populations? And so we know that based on, I won't read all the names out, but based on the research that a lot of folks did, that we know in a general community about 16% of females within a 12-month period were experiencing IPV, and with our active duty population, that's actually 29% of women. So almost double. And frankly, having worked in this population, I don't think that that number is very accurate. I think that it's much higher than that, to be very honest with you. So again, active duty, we're almost doubling our community rates, and within our veteran population, which means having left active duty, we've got about 22% versus that 16, so about 6% more. When we look at men, look at that. 15% of our men within our community have experienced IPV, but within our veteran population, we get numbers from 15 to 60%. That's wild. It's crazy. And then for our active duty men, it's about 18%. I'm sorry, that was perpetrating. That was perpetrating. I apologize for that. Victimization is actually 6% community, 26%, so 20% more within our active duty females. And within our veteran population, anywhere from 1% over to double. And we didn't have numbers for men for our veteran population, but look at that for our victimization from our community to our active duty men. Wow, big differences. So we know that these programs are so important. Where I see a lot of stuff with our active, I don't work on Tinker, but I hear a lot from our National Guard folks. And I do hear a lot of it. Our National Guard folks are doing similar work to our active duty. Deployments are often the same. And so when they come back and they touch base with us for their healthcare needs, there is a lot of stigma about talking about IPV, but I tell you what, we're experiencing it, and our men are experiencing it. I was in our lobby for about a 4-hour period a few weeks ago in January, talking about stalking, and I was shocked by the number of men that said, I've been stalked, or, oh, emotional abuse? I never considered that. Absolutely. My partner or former partner has abused me emotionally or financially. I work with many veterans who have used children to coerce men, and when we talk about our veteran population, a lot of folks who, once there's a service connection, once there's some dollars tied to a lot of domestic violence that happens, really sad stuff, and there's a lot of stigma to it, so not a lot of our guys are talking about it. So I'm very excited that we're increasing the conversation. Many of our gentlemen didn't know that the YWCA and all of our other shelters across the state do have space for men. I can't tell you how many men I've worked with that said, my wife beat me up, changed the locks, and now I'm at the homeless shelter. And I said, do you know that you can go and you can seek services? So it's not something guys are talking about, but I definitely hope that as we continue to grow that we talk about men being victimized as well. And frankly, as we see, our females perpetrating as well too. So we talk about that reality. So here's just some more prevalence. We know prevalence rates of use. We know that when we, that second line there talks about co-occurring PTSD and substance use. When those two things are co-occurring, we have a really high prevalence. And then our lifetime prevalence rates for Vietnam veterans, our gentlemen who are in their 60s and 70s, I can't tell you enough of how much I see of that where underlying issues are coming up at those times in their life, and I'm seeing a lot of prevalence of our older veterans who are both using and experience violence. So ranging from 33 to 58% of our Vietnam vets are women veterans experiencing IPV at higher rates than their civilian parts. Again, just reflecting on that. They're at a higher rate. And when we talk about our OIF, OEF, which is our folks that are just coming back from our Operation Enduring Freedom, 48 to 86% of our ladies who served in Operation Enduring Freedom have said that they have experienced IPV. Again, 48 to 86%. And I can tell you, having worked in both primary care and now being the coordinator of the IPV program, I see that. I'm going to briefly go over these. We know that there's a lot of issues that come from intimate partner violence, a lot of medical issues. One of the ones that I just recently heard more about and can't speak to enough is strangulation. And so you've got your TBI, you've got your cardiovascular, your headaches, your stressors like that. But a lot of our folks don't understand how quickly strangulation can turn, we know it's life-threatening, but how quickly that can turn into an array of other health issues. I was just at a presentation with Ray Goins from the Norman Police Department, and he talked about it's like 10 seconds. 10 seconds. And folks who have been strangled, they have symptoms up to 72 hours after, and the throat can swell. So when you guys are getting those calls, if our docs are not understanding the importance of that or saying, I don't see fingerprints, that was one of the comments that we talked about in Ray's presentation that someone had sadly experienced. Please, please, please advocate for those individuals. I know you already are, but the importance of the long-term effects of strangulation and the long-term effects of the stressors of intimate partner violence, those medical issues. Related mental health issues, depression, anxiety, PTSD from the experience itself, further substance use, suicide, and homicide. Social issues. As we know, intimacy issues, both with that partner should they choose to stay with them or with partners thereafter. Trust issues, isolation. Again, focusing on that work disruption, that's why we do add that in as something that's central to the VA. Poverty and housing disruptions. I'll speak to that for a quick second because a lot of people don't know that that exists. But if you are working with veterans who are being disrupted in their housing situation, I encourage them. We have a program called HUD-VASH, and what that is if the individual qualifies, their income qualifies for housing and they're a veteran, please reach out to me and I can get them with the appropriate folks. But our HUD-VASH program works with our veterans who are experiencing homelessness, and we also work with supportive services for veteran families, SSVF, and they help with our folks who are at risk for losing housing. So if you are working with folks and you know that they're a veteran and they may be at risk for losing housing due to the intimate partner violence, please reach out to us and we'll get them connected to who they need to. And then, of course, we know there's many types of IPV. Sexual, emotional, physical, and then we often don't understand or talk as openly about or realize the importance of stalking too. I think I heard the statistic, gosh, I think it was 25% of folks throughout their lifetime had been stalked by somebody and they didn't know that they were even being stalked. I don't know where that statistic came from, but I remember hearing that, and I thought, oh my gosh. Since I heard that, I've been a little on edge, because you really don't. We're all people that work in the community. We don't know who has our number, who doesn't, who has our personal address, who doesn't, who has our Facebook, who doesn't. And so we hear that a lot of stalking, that there's just not really great resources for stalking right now, but we at the VA are working to increase those. I've given you some signs of IPV. I'm going to go over those quickly just because some of them we might not think about. I know when I was just new to the position, I didn't consider some of them. Absences from work, school, or other regularly scheduled activities, frequently missed medical appointments, or if you've got appointments with folks and they're not showing up. I can't tell you enough how often that happens. That was my veteran, my folks who called this morning that said, you know, I'm ready because I had gone back. And I said, that's okay. That's where we're at, right? So what's going on that they're missing those scheduled appointments? Frequent accidents or injuries, cuts or bruises, wearing that heavier makeup, long sleeves throughout the year, tearful interactions, inability to maintain eye contact, limited access to funds, especially if they're service-connected veterans. Again, reiterating on that, a lot of our veterans will get a service connection, and then soon after we'll have a partner who might say, well, you're not responsible for taking care of your money because you have PTSD. I better take care of that. And so we see a lot of that financial coercion, both in our female and our male veterans. Anxiety and depression, a loss of interest, a lack of self-care, poor hygiene, of course, decreased or increased sleeping, stomach concerns, quiet, aloof conversation, quickly changing emotions. If the partner is present, everyone in the room feels tense. I know many of you experienced that. This one I hear a lot is excessive apologizing. That's one of the things that I've started picking up on when I'm even interacting with veterans passing by. If I hear sorry too often, I begin to go, well, what's going on? Tell me more about your family life. Identifying multiple sexual partners over a short period of time, a lack of identified social supports outside of that primary relationship, a fear or anxiety related to change in birth control, embarrassed or overly dismissive when asked about domestic violence, and an anxiety, fear, or sadness to return home. And I see that sometimes where a lot of our veterans will just kind of be wandering, and they'll take their time at appointments, or they'll kind of linger a little bit. I always like to ask, well, what's going on that you're lingering? I was going to provide some case examples and scenarios I have earlier in the presentation. I guess going back to, we don't know. There's so much that happens in people's lives, and we want to all be aware to be able to ask the question without that stigma on both ends. Veterans who are using violence, veterans who are experiencing violence. One last example that I'll give, I was working with a couple who came to one of my couples programs, which I'll talk more about in a bit, and the ability that they were able to say the female veteran had hit the male veteran. She was very upset, and the ability to talk about that openly, I don't know, a year ago, had we not had our program, that she would have shared that with anyone. And so now we're working on, well, how do we, I mean, that's a pattern. We didn't just get there. Her providers, again, working on not having a silo perspective, we reached out to all of her providers and said, what are we going to do on a holistic approach here so that this doesn't happen again, that potential for violence is significantly decreased, because we don't want that. So the VA has adopted the SAFER approach. So we screen with a tool called HIT, which I'll share in a minute. We acknowledge and we validate. Focus on safety. We use the danger assessment items to focus on that. We educate and we refer and document. With the HITS tool, we say that we're not able to complete that if another adult is present or if a child over 2 is present. We also, if the veteran declines to answer, we're not going to press on that. What we are going to do within our program and what we're working on as the VA is just making that, instead of populating those questions at the yearly appointments, they'll populate every 6 months, because we might not know that in 6 months that veteran's going to be ready to talk about it, or maybe not. So we give them that out. Within the VA, if the provider, and each provider will be trained within the year or 2 years to come with being able to do HIT. So your nurses, your doctors, we are working towards everybody knowing how to do that. So it's not just myself. Are going to be able to complete those screenings, be able to complete a safety plan. And I think what that'll do is it'll increase the conversation. If every provider within the VA knows that they can talk about it and that there's a resource available, it's not that big, scary, hairy topic, then we're going to be able to talk about that more, and we're going to be able to reduce the violent potential. That is documented in our data recording, but we're very, very careful and strategic about how that is documented, because we do know that those are medical records, so we don't document specific things. This is the example of our HITS tool. This is actually our eHITS. That last question about sexual activity has recently changed and is going to be reformatted in the months to come. But anyone who's getting over a 7, we ask within the hospital to refer to myself so I can refer out to you all or to further services within our hospital. So we ask all our providers to intervene. Again, safety first, completing those safety plans, making sure that all of our providers within the VA are comfortable doing a safety plan and are comfortable asking the question. And honestly, the only way that we get to that is if everyone's comfortable having the conversation, and we know that they're not right yet. So that's part of our education and our advocacy. Documenting that and then referring out to you all as needed. Also knowing that if there's children in the home, that all of our providers are mandated reporters. Currently at the VA, what we do offer for services is all folks are going to be able to, and are right now able to, do safety planning. Not all are comfortable, so I still do get a lot of referrals, but all people will be taught and educated on how to do appropriate safety planning and advocacy to our outside organizations. We refer a lot to the documentation that the Attorney General's office has provided for resources. We do have a group. Currently, that's only for our female veterans. I've tried to run a male veterans support group. However, my group hasn't taken off with my men. So we do individual for both men and for women. It's case by case. Sometimes it's short term, and usually it gets referred to appropriate department once the intimate partner violence issues have settled down a bit. We'll refer them out to our ongoing therapy, which is ambulatory mental health care, or if they do have military or military sexual trauma or PTSD, to our trauma and deployment recovery services. We also offer the Warrior to Soulmate program. If any of you are familiar with the PAIRS model, the PAIRS model was purchased, the rights were purchased to that by the VA IPV National Program last year, and so we do have the rights. We call it Warrior to Soulmate, but it is PAIRS. We offer that here in Oklahoma City quarterly. We've done 2 classes so far with about 15 couples having gone through that program. Our next one will be April 27th, August 10th, and November 2nd. We're looking to do something called Strength at Home. That is evidence-based programming for our veterans who are using violence. Currently, we do not have that. I keep getting a lot of calls for that. We're not able to do, that will never replace our batterers intervention programs. Those are the 52-week programs that are available for folks who are using violence. However, this could supplement it. Through our services, we don't have that available right now because we do need some more staff to sign up for that. However, looking to do that in about 2020, and that's again called Strength at Home. That's evidence-based programming. It's a 12-week, very intense program, 12-week, 2 hours weekly, involves the veteran who is using violence and follow-up with the partner if the partner and the veteran agree to that. Looking to do that in 2020. And then we offer psychoeducation. Groups like this to both outside organizations, our internal staff. If you're interested in learning more about the IPV program within the hospital, I encourage you guys to attend the OU Social Work and Healthcare on March 25th, and then look for the OU programming, the CEU credits. I'm going to be offering one the first Friday in April, I believe. So if you're interested in learning more, we do offer a lot of community presentations as well. you're all, I'm sure, familiar with our Oklahoma City resources, but in case you're not, we refer quite often to the YWCA. If our folks are 62 plus, which we do have a lot of 62 plus folks, you'd be surprised. We refer to Sunbeam, Palomar. I can't speak to how wonderful they are. You all are wonderful. I like to refer to Palomar quite a bit, and then our non-emergency police. Our VA police are not able to respond to things that are outside of the VA, but we work with our VA police for internal matters. And then the AG's office for the domestic violence sexual assault programs and the certified batterers intervention. And then our employees. So I can't speak enough to how excited I am for caring for our staff too. We know we can't do good work unless we are dealing with our own health and our own relationships. So we assist with our employees who are affected by IPV. We mostly refer to our EAP program, which is through our human resources. Our staff, if they do qualify for that, get 8 free sessions to talk about some issues that might be impacting their performance, that might be related to interpersonal concerns, or we refer out to yourself. So if you're ever open to any partnerships with that, please let me know, and I'd love to refer out to people as well, which I already do. I'm going to breeze over these a little bit, but some national or electronic resources, some safety planning, some apps for your phone, different additional resources, my references, and final reflections. Basically, the IPV program and why I'm just so excited to be working with all of you and sharing this with you today is that we just want to help families who are struggling. We want to build healthy communication and intimacy skills and preserve and promote those healthy relationships. We want to look holistically at those underlying barriers of connectedness amongst those who are using or experiencing IPV. We want to identify those early warning signs, such as the frequent arguing, name-calling, or threatening, and let veterans and their families know that early intervention or late intervention is available. We want to fully understand the contextual, situational, and bidirectional aspects of IPV that impact relationships, and we want to help veterans forego the use that would get in the way of veterans using their positive coping skills. We want to reduce isolation, particularly for those who don't feel capable of leaving safely, and we want to help folks leave safely if that's the choice that they want to make. We want to reduce the stigma of seeking help for any person who's experiencing or using violence, and we want to increase all veterans' sense of control and reduce veterans' feelings of helplessness. And last but not least, thank you, because it's people like you across our state that help us build partnerships with community agencies to reduce violence across the community. Thank you for your time. Does anyone have any questions today? I don't see any typing, so with that, I'll let you take the lead.
Sure, yeah. Thank you so much, Stephanie, for all this information.
Yeah, absolutely.
Because I can tell you from calls and conversations here at the coalition, sometimes it's really just like, well, what is available for veterans?
Absolutely.
You know,
yeah.
and where do we send them?
Absolutely.
You know, or if they are contacting a program, are they disclosing that they're a veteran?
Right.
And if they're not, how can, you know, advocates know how to most appropriately provide information and resources?
Absolutely. I see Sandy was asking to go back to the resource slide. Can I
Awesome.
go back to that?
Absolutely,
All right.
please.
Thank you, Sandy. Are you referring to the resources that are at the VA, I'm assuming? I'll go back to that, and I'll kind of talk to that a little. The website. Okay.
And so for folks that will be accessing the webinar a little bit later, who are going to be outside of Oklahoma City metro area,
yes,
and possibly the areas that you mentioned that are your service areas, Southern Oklahoma all the way up through, I think you said Stillwater?
Yes.
what are the services available at other VA health centers?
They
Do
are.
you have your counterparts and?
They are. So what we are doing a lot of is partnering with our primary care mental health. And the goal of the VA, they don't have it available in all sites, but they're hoping by the end of calendar year to have a on-site mental health therapist available at all of our CVOC sites.
Mm-hmm.
And so I'm really excited about that because each person who's going to be there is kind of going to be our liaison.
Awesome. Yeah.
What I'm also really excited about, which I expect will happen within the next few months, is that myself and many other providers are going to be part of what's called VA Video Connect.
Oh, wow. Like telehealth?
Telehealth,
Oh,
yes.
that's so awesome.
Yes, and
okay.
so what we can do is, again, part of our initiative is to really provide the training so that all providers can do it, but we know that sometimes you're going to need that point of contact.
Right.
And so for me to be available to do VA Video Connect with our folks who are, outstate anywhere, rural,
especially,
absolutely. And so I see just the benefit that we're going to have for safety planning.
Yeah.
And for that immediate, what do I do in this moment?
Yeah. Wow. So, that's amazing.
Yeah.
One.
Yeah.
But two, will that information and whatnot be available to the programs, and will they be able to tie in and say do that telehealth?
Yes.
Safety planning with you guys?
Absolutely. That's
awesome.
What they're expecting is that each site is going to have a dedicated space that they can do VA Video Connect. That program is fairly new, it's fairly developing, so I would say by the end of the year, but don't quote me.
Yeah. Okay. All right, guys, take note. Do not quote Stephanie on that.
Yes. But what I'm really excited about is the amazing way that I have folks who are in a city who, because of life, because of families, because of work, say, you know what, I want to be present in that group.
Yeah.
I want to be able to be talking about self-esteem and building healthy relationships, but I have to pick my kids up. Can I pick my cell phone up and can I be present?
Right.
And so as we grow the program to be able to do that, I'm just so excited for that.
Well, that's just amazing, and I think it would just be even more amazing if, other non-military, just any program that services victims or provides this type of information.
Absolutely.
I think that would just be so amazing if we all had that capability to do that type of video conferencing or video, communication, given that they're in a safe place to do that and things, but just how much more empowering it would be for victims.
Yes, absolutely. And I can't speak enough to how much the VA is growing to serve our veterans in all the unique places that they are, and places physically, but both physically, spiritually, emotionally. We really have looked at that holistically. And so I'm very excited for all those changes to come, to think that this program started with just a little seed in 2012, and now we're over 160 sites. I really expect. I'm very excited for the prospects. So I tell folks, it's up and coming. Look back frequently. Get in touch with me if you do have any further questions. I think that my name, number, and contact information is on here. But I always encourage everybody touch base with me pretty frequently because things change and they change quickly. So.
So it looks like somebody was wanting that slide up.
I don't know if that's the last one. Yep, okay.
No, there we go.
Perfect.
Awesome.
Any other questions today from the group? I want to thank you all for being here. And again, I can't thank you enough. We all have to be in this together to do this work. And so I'm really excited to be sharing what we're developing, and I'm so open to hearing what everyone else is doing too. I really open to partnerships and making it all work for our folks.
Yay! Well, thank you so much. This was fantastic information, and I'm personally definitely looking forward to more collaborations.
Absolutely.
Working with you, working with VA down there. Down there, I'm thinking over here.
Down here, over there, everywhere.
Yeah, everywhere, because you never know the backstory of who's coming into the to programs and
Right.
to services.
Right.
Because not everybody is disclosing their veteran status
Right.
for so many reasons.
Absolutely.
My ex-husband is military,
Mhm.
and so hearing the information and thinking back to my own experiences is like, wow.
Yeah.
You know?
I know when I present at OU, I'm going to take kind of that stance. So if anybody needs CEs and wants to get up to that, I know my ex is also military.
Yeah.
And I am pretty open and honest that I have experienced IPV.
Yeah.
And so one of the questions that was asked in the presentation that my predecessor did was, can it happen to anybody? And yes,
Yes.
absolutely.
Yes.
So in that presentation at OU, I don't remember if it's April 5th. I think it's April 5th. I'm going to talk more to that because that, to me, it's part of reducing that stigma.
Absolutely.
That, hey, here we both are.
Yeah.
Right? And that folks always ask me, my best friends ask me, shoot, the day of and many days after, why didn't you say anything?
Mm-hmm.
And so reducing that stigma.
Exactly.
Yes.
And also, you know, in addition to that stigma, stressing that, like you said earlier, it's not always physical.
Right.
You know,
Exactly.
and some of the most damaging, like almost, am I crazy, gaslighting
Right.
is going to, you know, leave, you know, more, I guess, bad taste isn't the most appropriate way to say it, but it's definitely leaving a bad taste because you don't have that, you know, that physical, the physicalness. Yeah. And so it's like, oh, well, if it's not physical, it's not IPV, you know what I mean, or domestic violence.
Absolutely, and that's why I can't stress enough how excited I am to develop this program, because when I'm in the lobby of the VA and I have our young veterans and our old veterans and everyone in between walking by, and I have my signs up that says what IPV is, people stop and they're like, huh, that's me. Yeah, and it's always it's always a different face in the mirror when you look. You know what I mean? But again, thank you so much. Don't mean to go off on tangents and bore anybody. So thank you all again. Just a reminder of your CDS VRP secret word, veteran-centric. So jot that down, take it down, write it down, remember it, because you will need it soon, just as soon as I get the quiz situation figured out. Thank you all so much for your patience. Again, I've been saying that on every webinar. So stick with us, hang tight. We will get that information out, quizzes and certificates, just as soon as we can. So you aren't missing anything, I promise. And thank you all again for joining us, and check back on our website and social media for the next webinar coming up. And you guys have a great day. Thank you.